Now we have our third speaker, who is Dr. Khadija Ali. She is a pediatric consultant and pediatric endocrinologist in Bahrain Salmania Medical Center, and she is assistant professor in the AGU. Her topic will be investigating children with recurrent fracture. Please, Dr. Khadija.
Good afternoon, everyone. Thank you, Dr. Abdel Jabbar, for the introduction. And I would like to thank Dr. Wiam and the organizing committee for inviting me. I'll speak about fractures in children. I have nothing to disclose. I'll go through introduction, incidence, causes, differential diagnosis, and evaluation of a child with recurrent fractures. Actually, fractures in children is quite common. Child risk of sustaining fractures is around 42% in boys and 27% in girls from birth till the age of 16 years. This is the opposite for adult. In adult, they have women fractures is more than men, but in pediatrics, we have it in boys more than in girls. And a fracture constitutes around 10 to 25% of all pediatric injuries. The most common site of fractures is at the distal radius, followed by the phalanges of the hands. Fracture rate peaks at the adolescent between the age of 18 to 15 years, corresponding to the period of maximum growth velocity. At that time, there is a relative undermineralization of the adolescent skeleton due to a delay of approximately 8 months between the period of peak growth velocity and peak bone mineral accrual, which leads to transient cortical weakness. Plus, increased participation in competitive youth sport has also led to concurrent rise in pediatric overuse injury, such as stress fractures. What are the causes? The main causes of pediatric fractures are trauma. Falls constitute around 50%, followed by child abuse and car accident, almost the same percentage. The pathological fracture or metabolic bone disease, it's very rare in pediatrics, it's around 1% only. As a pediatrician, we have to rule child abuse with any child with recurrent fractures. From the history, maybe if it is more common in children who are infant or unambulatory, if the fracture is so severe for the trauma history, it is an unusual site like in rib, for example, or if there is any other signs like ecchymosis, bruises, or retinal hemorrhages. We should all keep in our mind child abuse and recurrent fractures. Once excluded, we will think of pathological fractures. Those fractures caused by minimal trauma, it's located in unusual site, or maybe just found in the X-ray, and tend to be recur. Recurrence defined as when the fracture occurs more than twice in the same bone segment. And the differential diagnosis of recurrent fracture, actually the list is so long. But the good thing that we can diagnose or exclude it through a thorough history, physical examination, and selected diagnostic tests. We classified the fractures, recurrent fractures in children, causes as primary, related to the bone itself, or secondary, related to other diseases or medication. The primary conditions on the top of the list, osteogenesis imperfecta, and so many others, diseases of connective tissue, like Marfan syndrome, Ehlers-Danlos, osteopetrosis, hypophosphatasia, the genetic type of rickets, and it can be idiopathic juvenile osteoporosis, diagnosed when there is no cause of osteoporosis. The secondary condition related to other conditions, like inflammatory condition, SLE, inflammatory bowel diseases, when there is reduced mobility because of trauma or cerebral palsy, medication, top of the list, as we all know, the glucocorticoids and other medications. It could be due to nutritional vitamin D deficiency, celiac disease, cystic fibrosis, chronic renal diseases, or any infiltrative causes like leukemia. And we have a list in our endocrine as well, like hypogonadism, growth hormone deficiency, Cushing syndromes, and others. I'll speak about osteogenesis imperfecta because it's one of the common causes, and osteogenesis imperfecta happens because of a defect in the collagen number 1, in the quantity or quality of this collagen. And this disease is actually a spectrum, range from mild, happen in the adolescent, or severe. There are so many causes, more than 19 types, many types, more than 19 types. I put these 5, and most of them are overlap. The type 1 is the mildest one. It's presented adolescent, they have normal stature, gluten testiculata, and we have type 1, A and B, A with normal teeth, B with abnormal teeth. It is an autosomal dominant, so there is an affected parent, and they might have hearing loss develop in approximately 50% of the cases by adulthood. Type 2 is very, very severe, and it is prenatal lethal. Most of the types can be diagnosed through the genetic test, but actually if we have the clinical picture, we don't have to do the genetic test. And the treatment for these cases, the magic treatment is the bisphosphonate, and it showed to reduce the number and severity of the fracture in osteogenesis imperfecta. In our pediatric practice, we use pamidronate and zoledronate. The other one is just like opposite to osteogenesis imperfecta. Osteogenesis imperfecta is the bone is so weak. Osteopetrosis is the bone is so dense. It's also a spectrum of the disease. It's a rare group of inherited skeletal disorder. Also, it's characterized by increased bone density, and symptoms and severity can vary greatly, ranging from neonatal onset with life-threatening complication, such as bone marrow failure, to just an incidental finding in X-ray in adult. There are so many genes, more than 10 genes identified, and also since it's a spectrum, we have different inheritance types, like autosomal dominant, recessive, and X-linked recessive. The problem here is in the osteoclast, in the resorption of the bone. There is a defect in the development or function of the osteoclast, so there won't be any resorptive. Like the new bone will come on top of the old bone, so that's why the bone becomes dense and easy to be fractured. The features include fractures, short stature, compressive neuropathies. They can have hypocalcemia and seizures, and life-threatening pancytopenia because they have bone failure, pancytopenia. They might present with anemia or recurrent infection because of agranulocytosis. And the management here depends on the presentation. You might need calcium and vitamin D. If they have anemia, they will need blood transfusion, steroid needed, and the curable treatment in the severe cases is bone marrow transplant. Two examples of the primary causes. The secondary causes related for medication, I'll speak about steroid. Glucocorticoids stimulate osteoblastic activity initially in the first 6 to 12 months of therapy, followed by suppressing of osteoblastic activity, lead to decreasing osteoblast function and lifespan, and promoting the apoptosis of osteoblast and osteocyte. It has been found that more than 5 milligrams per day of a prednisolone or equivalent is associated with significant reduction in bone mineral density and increase in fracture risk within 3 to 6 months of the treatment. So is it the dose or the duration? Both actually, the daily dose and the treatment duration that we call it cumulative dose are responsible for the fractures. However, as the fractures often occur rapidly after starting steroid, the effect of fractures are probably more closely related to the daily dose rather than the duration. And when we use very high doses, like in rheumatology, anti-inflammatory doses of steroid, more than 20 milligrams of prednisolone or equivalent, the annual rate of loss of spinal bone density is around reach up to 15%. And they found that high cumulative dose of steroid, around 10 gram prednisolone equivalent, show marked deterioration in the trabecular microarchitecture characterized by thinning and loss of connectivity compared to short-term treatment. Hence, fracture risk reduction after withdrawal of steroid is less certain after long-term therapy than after short-term therapy. So any child will use steroid for more than 3 months. We need to do spinal X-ray and DEXA scan, and this should be followed up typically yearly if there is persistence of the risk factor, like if he will use steroid, there is an ongoing use of steroid, if he have low trauma, extremity fracture, if he have back pain, growth deceleration or cushingoid features, or decline in the spine BMD scores. Okay, there is idiopathic juvenile osteoporosis. We just diagnosed child with a fracture and osteoporosis by exclusion if we couldn't find any cause. And it is usually happen between 7 to 13 years of age, and they can come with pain, fractures. And the good thing about idiopathic is just it's improved by itself after puberty. They might not need treatment, and some might need physiotherapy and calcium and vitamin D, and some in severe cases they might need bisphosphonate, and some might need surgery because they just present with kyphoscoliosis. We do for these cases X-ray and DEXA to see. X-rays show us usually osteopenia, and the DEXA will see if they have osteoporosis. But most of the cases they have good complete recovery, good prognosis. Okay, if we have a child with recurrent fractures, we start with the evaluation. We take a good history because the differential diagnosis is a long list. So history and examination is very important. We should know the demographic data and the age of the child, the onset of the fracture, is it recurrence or just once, any other associated symptoms, does he have blue sclera or any other symptoms? Does the fracture happen spontaneously or with minor trauma, or it's a major trauma that caused the fracture? We need to know the growth of the child, his psychomotor development, his nutritional status, and if any medication taken. And we should keep in our mind any chronic diseases that might affect the fracture indirectly or directly, affect the child bone indirectly or directly. We ask about kidney diseases, hormonal diseases, and malignancy. And family history, if they have the same problem, they have osteoporosis or metabolic disorders, bony dysplasia. Examination, we look for general, the growth parameter, is the child short or normal, any bony dysplasia, blue-gray sclera, any signs of rickets, if they have any sign of rickets, and focal at the site of the fracture, if there's any inflammation or not. The investigation will be guided by history and physical examination. What we are thinking in our mind we will do. If I think it's rickets, I will just do the investigation in my mind to rickets. If I think it's osteogenesis imperfecta, I'll go in that way. Basic investigation to be done, like inflammatory marker and CBC, along with calcium, phosphorus, alkaline phosphatase, the bone profile in general with parathyroid hormone, and screen for celiac disease. Sometimes celiac, they don't have any problem, and we know celiac, they have malabsorption, and they can present with osteoporosis. What will help us most is the radiograph, the simple chest X-ray. We can see in the X-ray if there is osteopenia, sclerosis, ricket sign, metaphyseal widening, calcification of soft tissue, periosteal reaction, and it can show us also just a focal pathology or polystotic more than segment or generalized in all the bones. Let me ask you something here. You know what is this sign called? It's a child with a fracture, and we found this one in the scalp. Any idea? The one with the arrow. This looks like an extra bone between the sutures, and we called it Wormian bones, and it's a sign that we can see an osteogenesis imperfecta and other diseases. It can be also a normal patient, normal healthy child. Actually, the number matter. They said if it is more than 10, it will be significant. And what is this? Do you have any ideas? A fracture in his arm? Anything striking in this X-ray? Yeah. Anything striking you? The bone? Yeah, I know it's a fracture, but what can be the pathology? Now we will see the two different. The bone is very dense here, very dense. So this is osteopetrosis, when we have a dense bone compared to the normal one. And they have a fracture and osteopetrosis. And this sign, any idea? Does it remind you with, we call it copper-beaten skull. And the pathology usually here, if they have any increase in intracranial pressure, it causes this sign. And we see it in hypophosphatasia. When they come with a fracture and they have low alkaline phosphatase, they have copper-beaten skull appearance. This one is rickets. There is ricket exchanges and fracture. And here is like osteomyelitis as a secondary cause causing a fracture. So the X-ray is helpful. It can give us a clue about what we are dealing with. Then we can go to bone scan. Usually we use DEXA scan when we have a severe fracture or like long bone fracture of the lower extremity or a vertebral compression fracture or two or more long bone fracture of the upper extremity. And the one that we are using, DEXA scan, it's the preferred one. It's widely available and rapid scan, and it has low radiation. But we are in pediatric, not like the adults. We prefer the Z-score. We don't use and never use T-score in pediatric. And Z-score should be calculated at the standard deviation score compared with age, sex, and ethnicity matched groups. Why we don't use the T-score? Because it's overdiagnosed. Like here, a 12-year-old child, if we use Z-score for his DEXA, it is minus 0.9, which is normal. If we use the T-score, it comes minus 3.4, which is osteoporosis, and he doesn't have osteoporosis. Other we can use depends on
Time is running.
Okay, so this is just second line investigation that we are not using commonly, used according to the case you are dealing with, like bone biopsy and others. And the treatment, because the good thing in pediatric, if we have decreased bone mineral density, it's a largely reversible with remission or optimized management of the underlying disease process. We have to make sure adequate calcium intake and vitamin D for all patients, and we keep vitamin D above 50 nanomole per liters. Physiotherapy play a good, it's very important, and they have to avoid a lot of the activities and avoid taking heavy backpacks. And the specific treatments depends on the diagnosis that I diagnosed, and there are many medications for the diagnosis. For rickets, I treat rickets of secondary causes, and he needs bisphosphonate, you give bisphosphonate. Hypophosphatasia, we have the enzyme for the same as alkaline phosphatase. Thank you so much. I think I finished. The thing I want to tell you is just the pathological fractures in children overall rare, and the list is so long, and each disease, it had by itself a spectrum from mild to moderate to severe, and by history, examination, and investigation, we can narrow our diagnosis to reach the final diagnosis and treat. And if we find no cause and it's really osteoporosis, we say it's an idiopathic juvenile osteoporosis, and it has good prognosis. Thank you so much.
Thank you, Dr. Khadija, for this excellent presentation and very good review.